future of healthcare has arrived. Artificial intelligence and machine learning are transforming the practice of medicine and improving patient outcomes. This is Smarter Healthcare with AI. Conversations with Dr. Hassan Tetteh as he shares insights into the healthcare of tomorrow and how we can help create it today.
Today, I am joined by Dr. Zack, Chief Medical Officer at OpenEvidence. Super excited about this conversation we're going to have. He's a physician scientist at UCSF, and he's working absolutely on the front line of bringing AI to the bedside. Welcome. Dr. Zack, it is an honor to have you as our guest on the Smarter Healthcare with AI podcast. And there's so much I want to talk to you about. And I think for the benefit of our audience, I'd love if you could tell me sort of like, what's the origin story? You know, you have an incredible background, PhD in biophysics, Harvard Medical School, and now you're doing this.
Yeah.
OpenEvidence. First of all, what is OpenEvidence and how did you come to be in this position? And I'm sure our audience would love to hear that story.
Sure. Yeah, sounds great. Thanks so much for having me. I'm really excited to talk to you about this very transitional point of AI within healthcare. So, OpenEvidence is a medical search platform. I like to be very specific. Our goal, the problem we were trying to solve, is for a given clinical question to find the right references in the medical literature to answer that question, and then use those references to answer it accurately, which is a lot longer way of saying, take a clinical question and find the right answer, but it's a more accurate one, because I think without the right references, you shouldn't be able to trust the right answer, right? You, as a trust but verify clinician, you have to know where that answer is coming from. So that's what OpenEvidence is. We're now used by about half the doctors in the United States. We get over 1 million questions a day from clinicians at the point of care. So that's answer one. Answer two is a very long answer. I'll do my best to summarize. I was in physics in undergrad, went to graduate school in biophysics with no real interest in healthcare specifically. I was more imaging, kind of like single molecule imaging based. And then made a transition to being interested in cancer biology during graduate school due to some family health things that came up. So actually transitioned my focus and ended up doing my PhD in statistical algorithms in computational genomics, basically taking big data sets in cancer and understanding what was driving cancer back when we were doing a lot of bulk sequencing, trying to find drivers and passengers in cancer. I got the bug and went from that to going back to medical school. So went back to medical school in the health sciences and technology department at MIT and Harvard. And during that period, I got interested in machine learning as a way of moving beyond the statistics to actually making predictions based on past patients, what might happen to future patients. So got excited about that, moved to San Francisco to work with Atul Butte, who was really leading that field from the real world data perspective. Did residency, fellowship in oncology here, and started a lab. During fellowship, I got connected to graduate students at MIT who were interested in medical information retrieval using artificial intelligence. I started doing collaborative projects with them. They ended up doing something phenomenal called OpenEvidence. And I was dragged kicking and screaming from academia into a chief medical officer position.
Oh my gosh.
So luckiest thing to ever happen to me, obviously, but
Yeah.
that is the origin story regarding me and OpenEvidence.
So I'm sure our audience is probably now this is sort of a baited question, but I know what OpenEvidence is. I've used it myself. But some of my audience members may be like, well, OpenEvidence, how's that different than Google or ChatGPT? There's chat medicine. I heard about Claude. Yeah, just give us a little bit of, a bit of the distinction.
Yeah, so I'll go under the hood a little bit. And I do pride myself on being a medical educator. And I think it's very important to understand these are statistical systems. They're not magic, right? In the end, that there are numbers underneath it. And the first principle that separates what open evidence is doing from a lot of others is the perfunctory term that we talk about: garbage in, garbage out.
Right.
Um, and garbage is in the eye of the beholder, of course, but specifically what we mean by that is, what is the data being used to answer the question? And in a lot of the other models out there that are specifically focused on medicine, the data sources can come from anywhere on the internet, right? So, can come from PubMed, but can also come from Reddit blogs, or, or Facebook, or any of these other sources. So the first piece that makes open evidence different is the walled garden of what we are drawing answers from. And um, the big picture is PubMed, but not just PubMed. There's a lot of bad stuff on PubMed. So curated PubMed to make sure we are not incorporating predatory journals or pay for play journals, for example. Um, Licensed content, full text and multimedia from more and more publishers. So New England Journal, JAMA Catalog, Wiley, American Academy of Family Practice, etc. Publish guidelines where we're working directly with guidelines to make sure that things are up to date to the day, hundreds of guidelines.
Wow.
And then finally, FDA labels and drug information directly from the FDA and CDC and others. So it's a white list, more or less, right? It's
Right.
a white list of, these are things that if I was a doctor, I would use to answer a question. And so
Yeah.
that's one aspect. And then the other aspect is, what is the model trained on? And the
Hmm.
model to actually pull those references and get the right answers are trained on human expert physicians, recognizing that if you are asking a question in thoracic oncology, the human expert is not a PCP. It is
Right.
not a gastroenterologist. And so being very thoughtful that when you are training the model, the question is not a medicine question. The question is a gastroenterology question, or the
Correct.
question is a general surgery question, and that you have to find the expert to train the model that is in that expertise. And us having a specific focus on medicine allows us that kind of depth to create models that accurately answer. So that's all the under the hood stuff. What it is in practice is, you ask a question, it does look a lot like a Google search bar, but what you get out of it is what looks a lot more like a review article with references in line to say where we're pulling that information from, knowing each of those references are real, not hallucinated, and come from the sources that you would trust if you were, reading the paper as if it was written by a human.
Yeah. I
I
mean,
I
that
should
that
warn you ahead of time, I'm an academic, so you ask one question, I'm gonna give you a 10-minute thesis.
no, that's totally great. That's absolutely what we wanted to hear.
Yeah,
Open evidence is tackling something deeply foundational, like you said. It's the clinical knowledge itself. It's not just this vast array of like random things that happen to be tangentially related to my specialty, your specialty in oncology, or our colleagues in gastroenterology. So I think that was exactly what I wanted you to say. So it's perfect. So you think about the problem, right? You said it's knowledge versus care. You talked about your background, how you came to this, and we need information to make better decisions in healthcare. That's kind of like what we learned from day one in medical school. Um, what are the current challenges now? Why do we need open evidence in
yeah,
2026, right? I mean, we learned about Hippocrates and all these great physician scientists and Osler and my specialty, so a little bit biased here, but yeah, I mean, those docs did fine, back
yeah.
then. Why do we need open evidence now?
It's like you're teeing me up. We didn't talk before. I love this because it's not a problem that it is today, but it is a problem that I would say the last 40 or 50 years that has just been worse and worse, increasing. And that is this problem of the medical fire hose. And it occurs on two dimensions. So if you think about how Osler practiced like 150 years ago, or how he trained, he probably had like one mentor, maybe a couple. He learned some pieces of knowledge that would fit broad swaths of the population. This is how you treat diarrhea. End of story, right? Um, and he learned that, and then it was good for 30 years. Like, not much changed in how to treat diarrhea between 1850 and 1880, right? So you ended up, when you think about each quanta of knowledge, um, it covered a broader population, and
Mhm.
it covered them for longer periods of time before it went stale, and you had to learn something new for that, right?
Mhm.
Fast forward to today, and we just have had exponential growth in how much knowledge there is, how this um, how quickly it becomes out of date, and the population in which it addresses is smaller and smaller, right? Now it's not lung cancer. Now it's not non-small cell lung cancer. Now it's not EGFR mutated non-small cell lung cancer. It's 858 mutated uh, non-small cell EGFR non-small cell lung, right? And that's and I don't wanna be equivocal about this. That is phenomenal for patients, right? The fact that we get to say, "This is exactly what's right for you as a patient," is amazing, but it's extremely hard for doctors, who are still the same human beings they were 150 years ago, to keep up with how fast that changes and make sure every patient is getting the evidence-based care that they should be getting. And so the problem Open Evidence is trying to solve is keeping doctors up to date with those evidence-based recommendations as they change every month and as they affect smaller and smaller pieces of a population. And, um, I think that that's what's hit the nerve and why we've grown for by word of mouth, over 2 years to being half the doctors using us. And I like to what I like to point out is, like, that the proof of that is doctors are not using open evidence the way the New York Times likes to pretend they use open evidence, right? They're not asking, "What's the differential for my shortness of breath patient to look for zebras," right? When we look at our data, the majority of questions are about treatment and management or side effects or special populations. These kind of things that change rapidly in the literature, and the doctors just trying to make sure that they know what's most up to date.
Right.
And that's very different again than a lot of the lay people think that we're using it for differential diagnosis creation and when we do, it's often just to kind of expand what we already have as a strong foundation.
Yeah. Let's unpack that a little bit because that's a really important, critical thing. I think it'll resonate with the audience. And I'm gonna help to bring this out, this point that you made, because I think it's really important. Let's talk about time. Like all of us in a healthcare ecosystem, whether we're the patient,
Yeah.
we're the administrator, the leader, the person doing the coding, certainly the doctor,
Yeah.
are very, very
Time pressure.
sensitive to time, right? So what's the hidden cost clinically and economically of physicians spending time, hours searching for answers that may not be readily available to them when you have something like open evidence?
Right, right, and, where we're quantifying this, and it's really scary in my mind, because the hidden cost is that it's not that they're searching for hours to find the information, it's that they just go with their gut and don't. Um, and so you can imagine uh, there's somewhere between 3 and 5 questions for every single patient that a doctor has, that they aren't 100% sure they know the answer to. Most of those, they're probably 95% sure they know the answer to, right? They're like, I saw a patient like this 2 months ago, probably not much has changed, or, I mostly remember the right way to treat. The last person I saw didn't have CKD, chronic kidney disease, but I'm sure that it doesn't matter in this case, right? For a lot of those, it would take me 20 minutes in the old way, going through PubMed or traditional resources to go find the right answer, which I'm 95% sure is right, right? So what happens is they just don't. They're just like, I'm sure I know it. It's fine. It'll be fine." And then there's some threshold of certainty where they do look it up, right? Because doctors, they're in the end, they take their patient care very seriously, all of us.
Right.
Really.
Yeah.
And so, maybe it's 70%, right? If I'm 70% sure, I'm looking that up, even if it takes me 20 minutes, right? I'm gonna do it. I'm gonna make sure I do the right thing. Um, and there are other dimensions for that. But so what we're seeing is now that it doesn't take 20 minutes, it takes 5 to 6 seconds. Now people are going to external resources and that is open evidence and going with their gut less. And so I'm not actually sure we're saving some time, but it's less about saving time. And I actually think people are providing better care because they are more certain in their answers. So there's that aspect. For the burnout perspective, and people talk about burnout as if burnout and time spent are synonymous. And I actually disagree.
Yeah.
For me, when I'm practicing, there's the time spent and not getting to spend as much time with family and all that. But there's the, like, moral cost of all those 95% decisions when I go home at night, and, like, worrying, "Did I do the best thing?" every
Where
time
you do
I go to bed,
the
and worrying that I didn't because I didn't have enough time. And
right.
so I think that there's a burnout element here, maybe less about time spent, but more about being more certain that I did the best care that I could have because I was able to actually look that up and make certain of it. So those would be the 2 aspects I think about, a little bit when it comes to and we're running some prospective trials to kind of go through that, to say, how often are people going to external resources when they do or do not have a tool that provides it in 5 to 6 seconds versus the traditional approaches?
Yeah. So let's give us a real world use case for exactly what you just said. I complete everything you said resonates with me, right? So yeah, I get it. But like, tell us a real no kidding use case of exactly that workflow that you just described so greatly and eloquently using the open evidence,
Absolutely. So,
solution.
let's just I'm gonna come up with an example, of a PCP, and patients are getting more and more complicated. So the patient,
Right.
is mid-50s, has type 2 diabetes, um, has hypertension that's long lasting, and has a new diagnosis of heart failure, right? Uh,
Complex patient.
Complex patient. And the PCP is like, "Okay, I'm gonna try and do my best to figure out what's going on with the heart failure, but you're gonna have
Right.
to see a cardiologist," right?
Right.
It's my guess is and so they walk through kind of the steps, and at the end of the visit, there's a bunch of things now they have to cover, right? They're like, "Okay, is your hypertension under control? Is there anything you have to do different for your hypertension? Your diabetes, is there any agents that change now that you have heart failure versus, before when you did it," right? And just and then just medical management before you get to your cardiology appointment. And
Right.
so those are all questions that the PCP has to decide, and they still have the same 15 minutes that they do for every other patient, right?
Right.
And so in the old way, what they would probably do is their best attempt to figure out what are the 2 things I have to make sure I'm safe with for this patient regarding the changes in their medical management and teeing them up for their cardiologist, right? In the few minutes I have left. Those are the ones I'm gonna do my research on. I'm gonna go to the American Diabetes Association guidelines, spend the 10 minutes finding the right page, go to the American College of Cardiology guidelines, make sure I have the right page. And the rest, I'm just gonna do my best and just kinda check the boxes and either that or just postpone to the next visit, right?
Right.
And I know that sounds terrible, but that's the healthcare system as it exists right now. And right now, instead, what we can do is you can actually type that complex patient into OpenEvidence and ask the question, how does the current what they're I'm currently doing change given this new diagnosis? 1. And my second question is, they're gonna see the cardiologist in like 3 weeks because that's how long it takes to get a cardiology appointment, best case scenario. What are the things I need to do to make sure that he's ready for that cardiologist appointment so the cardiologist doesn't say, "Okay, see me in 6 weeks after you've accomplished all the things that were done by your PCP," right? And then that's a list of things that they can now do and make sure are done for that patient that before they wouldn't have had the time to actually accomplish. I don't know. Again, that's totally off the cuff, but that's an example.
No, it's absolutely incredibly accurate though.
Yeah.
This is exactly what's going on in exam rooms and hospitals and clinics all over the world right now, particularly in America for sure. You know, that example is, I think it's very appropriate, off the cuff or not. I think it will resonate with certainly anyone that's been on either side of that equation, the care provider side or certainly the patient side, where you just get this sense, this tense feeling that this person is very, very under the gun for time. They're trying to do their best, and they may not have everything at their fingertips to be able to provide the best. And if you think about, this construct of what you just, laid out, and now having, a paradigm that's starting to evolve here where we're able to sort of synthesize this information in a better way to provide better care for the patient. What has surprised you as the chief medical officer that you're getting feedback? You mentioned this several times. You're getting feedback from clinicians. What has surprised you most about what clinicians feel in terms of their experience working with open evidence in real practice?
Um, I'll tell you what surprised me like 18 months ago or 2 years ago when we started, and now it's is less surprising. But it's still heartwarming. And then I'll maybe talk a little more about like what's surprising this day and age. What was surprising to me, when we started, because it was all word of mouth growth,
Hmm.
were how many doctors would email, and it was word of mouth growth. So, me and the engineers, we would look at our email just
Wow.
constantly, right? Like our contact list, we would read every one of those. We would respond to every one of those.
Wow.
Um, like literally the co-founders, me, like we would all do it, right? Like that was part of our job because it was small. And what was so surprising was the rate of word of mouth growth about just how many people would be I'm telling every one of my friends about this. This has changed my practice. And the number of doctors that would say, "This is so exciting. What can I do to be involved and help?" Like, even if it's just doctors, again, I don't know compared to scribes if there's a time element that is as if, I'm not sure we're saving as much time as scribes.
Hmm.
But I think it hit a nerve in such a way that, there's this part I described that scenario, and I'm sure you or, I've been in that situation. There's that nerve that we hit about a missing piece of, the the moral concern that we have that we are being put in a position where we cannot provide the best care for our patients because we don't have the time.
Right.
It's not something that saves us time, it's something that actually makes us more confident we're doing the right thing. And that nerve, like, just the feedback we got, just thank you for hitting that nerve and fixing that constant pain in the back of my mind, that I'm not quite sure I know the right thing. So that was really, surprising to me early on. Now it's sad, it's like now it's great, but it's not as surprising anymore, like, we know. Um so that's one. And I think the thing that's been really surprising to me is we've built a flexible evidence engine, and hearing from doctors all the ways they're using it that we hadn't actually envisioned or built. But because it's based on a strong evidence engine, there are all these other ways that they're able to use it, that we hadn't actually built, and then finding ways to actually support that. So, you know, um, things that I'll just things that we're building now, I'll just mention, right? Like we've heard from surgeons, you're great at as an evidence engine, but what I really wanted is to know all the different ways I can do this procedure, which isn't necessarily evidence, but should be out there somewhere, right? And
Should be right. Yeah. Yeah.
evidence does an okay job, but that's how I want to use it. And so now we're doing this whole initiative this quarter on how to be better for surgeons. And that includes adding in videos, that where it's not just a video of the full surgery, we're actually doing computer vision to figure out what is the right video in right clip in an educational video for exactly the piece that the surgeon's asking about, so we can put that in line so the surgeon can actually watch someone doing it. Um, or talking to surgical experts across the United States for the areas where, we've gotten thousands of questions from surgeons where there isn't any evidence, but maybe expert guidance is the right approach, and just making sure we find that expert and attributing their content. So, those things is like having someone either tell us something that they're using open evidence for that it's working really well and we didn't know is a use case and supporting that use case, or having someone tell us, I want to use open evidence for this. It's not great. And then we're like, great, let's figure out a way to make it great. And so all those, medicine is it's a long tail field, right? And one of the reasons static resources don't work for long tail fields is you can't cover every use case. But one of the things that we're learning about this long tail field is as we learn from people about how they want to use the tool, we can start to support them more. So that's been another thing that's been surprising is that feedback loop once we have so many people using it has been really great.
Well, that's incredible because I have to confess, I'm one of those people. I heard about heard it was word of mouth. It wasn't a billboard. It wasn't an ad anywhere. It was like, one of my colleagues, very trusted colleagues, say, "Hey, you check out Open Evidence." I'm like, "What's that?" And I log in. There's a verification period, process that you go through to make sure you're a doctor and everything. And I logged in and got the account and started asking questions. I was like, "This is phenomenal," because there's like a source cited for where this information's coming from. It's not, you know, purely random. It looks like this is like some really, really vetted, legit stuff. So this is really good. And to your point, I think the way in which the information is delivered from the queries is really helpful.
Yeah.
So now here's a bigger question. All right. If AI and open evidence can give every clinician access to the world's knowledge, right? Vetted, you know, peer reviewed, what becomes a new differentiator for a great or world-class physician or surgeon now?
Yeah. Well, I'll put aside proceduralist because that's a whole nother step. You guys have your own moat. But I think there's a lot of similarities in what I would say is the general moat, of like what makes humans different and what makes one human different from another. Um, and um, it goes back to this, like, what Osler did versus what we do now.
Right.
And I think there's a lot of um, identity. So I would say that there's two pieces of a physician identity that we feel strongly about based on our training. And one of which is very inhuman and is actually rather new for physicians, and the other one is very human and has been part of the physician identity for thousands of years, right?
Mm.
And so the first one is, well, I have to know everything that's ever been published in medicine or I won't be able to practice right,
Right.
right?
Yeah.
And you know, that's again this new thing where that it's been true, right? Like if you didn't know that if it were in the 90s and you had to look up every single thing and take 3 hours for every one,
Yeah,
you
you
wouldn't
wouldn't you
practice
wouldn't survive.
medicine,
Yeah,
right?
yeah,
Um, and but it's become more and more of identity as it's become harder and harder to do because it's the differentiator, right? It's like if I know everything, I become the better physician because I'm constantly reviewing the New England Journal. I know the latest trial when it comes out. And then there's another part of the physician identity, which I think both physicians have in equal parts, which is um, I am I've used my experience and my reasoning and my empathy to take what I know and apply it to the patient in front of me, right?
right,
And
right,
all those things are so human, right? And so important, which is I've seen 30 cases of individual patients that have this exact same thing or something similar to it. I know how this plays out. I
right.
know how to balance the efficacy of the drug and the toxicity of I see in front of me. I know the different outcomes. I can pair that with the quality of life things that the patient's talking to me about. And I would say, those are things that a physician has been valued as a physician again for thousands of years, which is the
Right,
experience, the reasoning, the
right,
empathy. And those are very human tasks, right? So I really see the differentiator focusing more on that second aspect as we do a better job of taking away that inhuman task, which is the entirety of human knowledge generation.
right,
And I think that's and for me, I think that's a good thing in a lot of ways, right? I wouldn't want the differentiator necessarily to be, did I read the New England Journal when I woke up this morning, or not, right? Um, so that's where I see a lot of the differentiation going. And I'm in the I've looked at 150 million questions, right, more or less, right? That's how
right,
many questions we've had asked. The other thing I like to give physicians credit for, they don't give themselves enough credit for, is the job is very hard and it is not in a textbook. There are
yeah,
very, very few questions that get asked to open evidence where there's this textbook answer that is right here, or even if it is, that textbook answer perfectly applies to the individual patient in front of the physician.
and the case in front of them, correct. Yeah,
And so
absolutely.
that extrapolation layer is something a physician doesn't give himself enough credit for. That is really hard and nothing that can be trained, right? We don't have the data to train that
Right.
extrapolation layer. It's never in the cohorts in the randomized control clinical trial.
Yeah. Well, I love that. I love the fact that I'm often fond of saying this. I think that AI, for everything that people have an opinion about its application, its use, its permeation into every aspect of our human lives, I think that if it's used correctly and leveraged appropriately, it could actually help us to be more human.
Yes. Yeah, exactly. Exactly right. Yeah.
And help us to be more human. So to your point of, the great differentiator for the great physicians in the future will actually be that, we are more human, we are more empathetic, we are more caring because we can take knowledge now and leverage it, but bring in, like you said, that layered approach of like synthesizing that information so that that answer that's not going to be in that textbook per se or in that study per se, we can use the patient in front of us, our experience, what we have and gain from the interview, from the listening to the patient, from the being empathetic, for understanding all of the things that are kind of coming into play to provide the best care possible. So if you take all of that now, the natural next question must be, how should medical education evolve in a world where recall is less important? So
Yeah.
you said, well, the great doctor knew everything. Well, in the 1800s, there wasn't a lot to know. I mean, there was a lot to know, but there wasn't a lot to know relative to 2026. So the differentiator now is a little bit different. And when you think about medical education, the future of education and healthcare in particular, many medical schools are considering, and some have already gone so far as to start truncating the amount of time because those first 2 years, as you and I know, we were that generation where you got to memorize as much as you can
Yeah.
so that when you get in front of a patient, you'll know enough to be able to have a clue.
Yeah. Yeah, that's exactly right. I love that. Exactly.
So now you're like, that may not be so important, right? If you
Yeah.
can really get, a lot of information right at your fingertips. So how do you think medical education should evolve in this world that we're moving forward in, and you guys are certainly pioneering through open evidence?
I have biases because of what I value in medical education.
Sure.
So I take it with a grain of salt. But I think the individual facts about treatment, management, that's gonna matter less, and it all comes down to what I talked about is, like, what is gonna be the differentiator, and that's the reasoning component. And in order to have a strong reasoning component, in order to be a good reasoner, you have to be really flexible, but still understand the fundamental processes, right? It's like, I think the first principles are gonna be more important than ever because, like you said, you have to have enough knowledge before you go to the bedside to actually put anything in context, right?
Correct.
And I think it'll be less about what is the first line agent or how does spironolactone work or any of those. But I think the basic physiology, pathophysiology will still be really important to put anything that you get from, you know, the language model about the first line treatments into context.
Right.
So because you if you don't have those fundamentals and you can't reason, you are just a pass through for the language model to tell you what to do, right?
Right. Yeah.
Um, and so I really think I'm really to me that's very exciting because it's again it's more human that it's like yes, I still think there's going to be a fair amount of some memorization, but more around pathophysiology and reasoning and how the kidney works and how it relates
Mhm.
to the heart and those
Mhm.
kind of things. I still think that's very important because it's the building blocks for which you can start to interpret all the recommendations that you will be getting.
Mhm.
Um, so that's one aspect, and then the other one is I think using tools like Open Evidence for your education in an active way. So I like to talk about um, using open evidence for training. And there's a lot of, just like when Google came out and people who were trained on textbooks were like, no one will have to know anything anymore. They have Google, right?
Yeah. Right.
And all our trainees are going to be um, untrained and lazy and not know anything. And it ended up not being true
Right.
because it's so much easier to find the piece of information and learn from it if you have the internet than if you had to go to the library every time you didn't know something, right? But it involved in order to be good at it, you had to actually involve an active process. And so I feel the same way about open evidence, which is active learning with the tool, not passive learning. And so the passive learning is, oh, I have this patient, I'm gonna just copy paste all the information, and then I'm gonna ask the question, what should I do? And then I'm
Right.
gonna take the answer from that, I'm gonna copy paste that into my note and tell my attending I did all the work, right?
Right.
I mean, I'm being reductionist, but that is in the end, that is the passive model, right?
Right.
Um, and the active model is say, okay, here's my patient. What is my question here? What is it that I really need to do for this patient? And what are the pieces of information from this patient that will help me answer that question in the literature?
Right.
That's a very active cognitive process, right?
Absolutely.
And doing that right and wrong will help you learn what are the pieces, what are the questions, right? That's an active process you can learn from. And then active output, which is when you have that output from the answer, critically evaluate it. Is it answering the question that I wanted it to answer? Is it answering the right question? Does that answer relate to my patient in a useful way? How
Hmm.
do I extrapolate the evidence in that to my patient?
Hmm.
And I said that sounds exhausting, right? But what I try to tell a trainee is imagine having to do that with a traditional tool.
All
That
right.
would have taken you 40 minutes. And we were in the I'm sure you were a resident and you did
Yeah.
that, right? It did take
Yeah.
40 minutes.
Still had to go to the library.
Right. So now the getting that information itself took 5 seconds.
Right.
So maybe takes 90 seconds to do those other pieces. And you still saved yourself 18 minutes of time, right? Like, and so, for trainees especially, I like to frame it that way, which is like an inoculation procedure, which is, look, you still have this dual responsibility as a trainee, which is not
Right.
just to the patient in front of you, but to your future patients. And those 90 seconds that you use in active use of these tools, those are all given to your future patients, to actually learn as you use them. And I think if done that way, I've definitely learned a lot more and been a better doctor because of this tool, not just to current patients, but future patients, because I am doing things not because my attending from 10 years ago told me this is how to do it. I'm
Right.
doing it because I actually understand why he told me because the primary literature is there. So
And that's different. That's a different type of understanding and
exactly.
application of the information. Absolutely. So I want to shift a little bit in the discussion because open evidence is clearly geared toward the physician and the provider.
Yeah.
I've been, observing, as I'm sure you have, that there is no longer a monopoly on knowledge and information. Let's
Yeah.
put it that way, right? Knowledge has somewhat become democratized, and I'm kind of shifting gears and sort of putting myself in the shoe of a patient, which many of us have been a patient as physicians, even though we're doctors. We are, on occasion, have to be a patient, or our family members have to be a patient. And I have my watch on that collects all this data and information, and I may not have open evidence as a patient, but I have access to a plethora of information I didn't have before. And now those patients are taking their information, they're uploading information, images, their own clinical record. And I call it this asymmetry of knowledge and information, and potentially even asymmetry of power, right? When you come to the encounter with the doctor and the patient. How do you see this new paradigm, this system of healthcare, as we call it, as we know it, in terms of who controls this knowledge now, right? Who owns clinical knowledge in this AI era?
Yeah.
What's your perspective, sort of in your place as a CMO, but just as a global citizen? How do you look at this now?
I have a lot of thoughts. I'll try to organize. um, so so I'm sure, I shouldn't um box people. I'm sure, you do a lot of in your field, you take care of very, very serious conditions, right? And I mean serious from a patient perspective. Somebody comes to you, they probably have been given a life-changing diagnosis.
Yeah,
Same,
yeah.
same like
End stage something. Yeah.
same
Yeah.
like in oncology, right? Like
Right.
life-changing diagnosis.
Yeah.
Um, I don't think there's been a point in time where somebody gets a life-changing diagnosis and they haven't done everything in their power to get information on that diagnosis, um, before they actually get to see the clinician. Now, people are different. Not everyone does that. Some people prefer not to. But, before chat and these, there was Dr. Google, and I don't think people leaned any less hard on Dr. Google than they're line on chat now. So my perspective has always been, um, patients are gonna do whatever they can to get as much information as they can about their health,
Right.
especially in cases where it's a life-changing diagnosis
Sure.
or for
Yeah.
themselves or a family member, right?
Right.
And there have been other kind of a few different sources for that information. One is the doctor, two is friends and family members, and three is external resources that are searchable. And the internet is one. Chat, there are all these, the library, whatever it happens to be. But doing your own research, right, is the third.
Right. Yeah.
And for most patients, I think that a lot of those carry equal weight in a lot of ways, right? Um, and I've personally felt that patients should have the autonomy to get that information external to a physician,
Mm.
and because they're gonna do it anyway,
Right.
and it's their right. It's their right to information, right? They should have that information,
Right.
and, from a personal perspective, which is a little different than where we are at as a company, um, is I would love them to have the same medical-based, information resource that physicians have, right? So, I that would be my goal, and I think it should be democratized.
Mhm.
I will put some caveats on why I think it's dangerous, but
Mhm.
I still think that they're gonna do it anyway. They might as well have it from it's the same source that a doctor would trust.
Yeah. Trusted, right?
The reason that we are not there's a couple reasons that we're not doing that as a company perspective, and it's really more or less because, one, we really truly believe that if patients deserve that, they deserve something that was built for them, not built for doctors and then released to them, right?
Right.
That's
Yeah.
slightly different, right? The
Sure.
knowledge base may be the same, but the
Right.
product would be different.
And how it's presented to that population for sure.
So that's one, and then the second one is we are a very small company that's grown just incredibly fast in the physician space, and so it's like if we really believe that patients deserve that own product, we should dedicate the resources to build that product, and we just don't have those resources. So that's just where we're at. But from a broader perspective, either you believe that patients deserve all the same, that information, or even if you don't, you should recognize they're gonna try and get it anyway, right?
Yeah.
As a physician. So, I am overall generally positive about this. I think that AI, despite its risks, despite its errors, is still a lot better than the Google search page rank in terms of, the way people used to get in and the misinformation people used to find on Google. Um, then though I will mention the one thing that I'm nervous about and where the physician I still think needs to play a part is the unknown unknowns that patients deal with,
Mhm.
and a bit of the sycophancy that AI deals with. And that is when a patient says, "I have type 2 diabetes and I heard there's a new drug available for me. Would this be a good fit for me?" There's still a lot of cases where, AI regresses to the mean and assumes that that person has type 2 diabetes, right?
Right. Yeah.
Maybe they have type 1 diabetes,
Right.
and
Yeah. Or don't have diabetes.
don't have diabetes, and so right, and so, um, the unknown unknowns is something that we benefit from a little more by working with clinician audiences, which is the physician knows the right input and how the specifics that are important for an answer in a lot of parts. Whereas a patient may not, and that may lead to incorrect answers. Even if it's correct, again, even if it's accurate based on what was given, it may
Right.
not be accurate based on the full context, right?
Right.
And a patient doesn't necessarily know that full context as well. So I think there are a lot of challenges there, and I think that's where I think we have to be really careful as physicians when we hear, "Oh, chat told me this. Oh, my AI told me that." It's like, well, what did you tell it? Right? Like it's hard, right? It's like,
Right.
um, so
Yeah.
I I really want the end to be something that is more helpful for physicians, where the tool allows the patient to interact with it and get answers, and then somehow summarize or distill that conversation in a way that makes our life and intake easier so that we can help be a guide for that whole 4 weeks that happened before they came to us.
Right.
without getting a printout of here's all the things the chat told me.
Right. Right.
Um,
Yeah.
and I think we'll get there. That's what my hope is, and we'll end up in a better place.
Yeah. Well, you've been extremely generous with your time, so I want to start to sort of close, but I take it from our conversation that you are somewhat of an AI optimist, as I am.
Yes. Yes.
That's fair to say. So great. So kind of in that guise and context, being inspirational, sort of forward looking. I can't help but have you know the brain trust that is Dr. Travis Zack in front of me and not ask these very pressing questions that I'm sure everyone wants to know, right? If you could wave a wand, look in the crystal ball of 5 to 10 years from now, what do you think the future AI augmented clinical encounter will look like? I mean, we know what it looks like today. You gave us a good picture of 2026, but 2030, 2031, where do you think we're going to be at that point?
So my goal is that right now, um, we're doing a very good job answering questions that clinicians bring up. Um, but I think we're learning very quickly what questions they should be asking.
Mm,
Um,
interesting.
and I believe in 4 years, a lot of the questions, we will be the ones asking it. The AI system will be the one asking it, and it can be done before the visit occurs.
Mm,
And my hope is that a patient won't have to wait for their 6-month follow-up to know when some new clinical trial has come up that might change practice,
right.
or hope that the physician has noticed that trial, by the time of the visit, right? And so what a clinical encounter will look like will be one one in one scenario, this clinical encounter was created because, of an emergent situation that we feel like this patient should be seen, based on X, Y, and Z. And here's what we think your clinical expertise will be very valuable with as a clinician to address and discuss with the patient. And there are these other 4 things that we have identified that we actually, you should check them, make sure they're right, but we don't really feel like it requires a human judgment to refill their losartan, for example, right? Or to, maybe even, their CKD is a little elevated to recheck this lab so that it's done for you by the time of the visit, right? So, my hope is that it isn't this, uh, there's a lot more passive things that
Mhm,
do the triaging, so the clinician can really focus on the human elements, and
mhm.
some of the box clicking that happens in operations in EHR gets somewhat automated and to the benefit of both the patient and the physician.
So you think agents will play a role in exactly what you're describing?
Yeah, so more. I won't dive into these. Yes,
Okay.
I like agents as a word that gets thrown around. I just would prefer to say, yeah, there will be.
Autonomous
Right, there will be
activity.
autonomous because agents and autonomous are slightly different in my minds, but yes, there will be more autonomous systems that
Mhm,
act as sentinels
mhm.
where, there's less requirement for the human, to actually initiate, and I mean that from both the patient and the physician side.
Yeah, that's great. Well, you've given us a lot to think about and to consider, and I just really, really am so grateful to have had this time with you. And what I thought would happen, and I think our conversation, sort of progressed in this way, even though I couldn't script it out if I could, if I could have thought about it, was that we started off this discussion about your amazing career and what Open Evidence is doing, which is clearly AI. I mean, it is cutting edge, no kidding. This is AI. But at the end of the day, it's not really about the technology. I think you articulated, in so many ways and provided so many robust examples, not only in your own experience, but in the experiences you've had channeling the feedback you've gotten from millions of physicians saying, "Listen, this is allowing me to be more human and take care of patients better." And I think I've been trying to convey that in the smarter healthcare with AI sort of discussions and sort of illuminate that this is a scary time for many because there's a lot of unknown
Yeah.
things, but optimistic, and I think you share in this optimism that things like OpenEvidence and these tools that we are calling and defining as AI can help us deliver human care and do it in a better way.
Yeah, I totally agree. I would say my one cautionary thing that I want to be very thoughtful of as a clinician whose primary interest should be our patients, is
Hmm.
that there will be push, I believe, from operations and the top to use these tools as a way to argue for even more efficiency and less time with the patients. I
Mm.
think we have to speak with one voice to say, no, these tools allow us to get to where we should be when we haven't been able to get regarding that human element and the time spent with the patient, not allow us to move 15-minute visits to 8-minute visits. And I just worry that if we don't have those kind of active conversations about this is something that fixes a problem, not something that allows for, even more efficiencies and less time, then it will kind of be forced on us. So we should have that active voice to be, this is a way to improve the actual human connection, not a way to improve efficiencies in the healthcare system.
Yeah, I think that's a very appropriate way for us to close. Absolutely. I would say you should repeat that again. What's
I
the
repeat it to
action?
anyone who will listen.
Yeah,
That's
what is the one action that physicians and all of those that are involved in this this dynamic world right now should focus on? And that is, I think you're absolutely right. Like, let's not make this so that we get a way to put more input into the day, but actually give us more time to do the things that are really meaningful for patients and as us as professionals that are delivering care.
Thank you so much for having me. It's been a fun conversation.
This has been Smarter Healthcare with AI. If you'd like to find out how to bridge the gap between medical experts and tech innovators and discover how AI can make us healthier and more human, go to Tetteh.com. Smarter Healthcare with AI with Dr. Hassan Tetteh is a production of Forbes Books.